So I think one of the aspects we've discussed already is the whole point about planning the procedure before you start. And I think one of the things that worries a lot of people is the lower part of the dissection and how you're going to get right down, how you're going to get a staple gun on and how you're going to rejoin the bowel. Mark, could you tell us, does robotic give us advantages? I think that's important for us to discuss.
From our experience, the robotics does give us advantages in terms of being able to get into a tighter space.
Is that compared with open or
compared with
laparoscopic
both,
or both?
Or with both. And one of the things that we've actually noticed with these very low ones, and we're talking now in males with a narrow pelvis, probably large males with a high BMI, is the space is tight, and we all know that from open surgery, where often we're doing the lower bit by feel rather than direct vision sometimes, just to get the position. But it's easy.
You can't do that with your robot.
And you can't do that with your robot. And with your feel, you can get retraction so that you can see something. But with the robot, we are able to get retraction. We're able to get into a very tight space. And what we've found is that on occasions where we felt that we've actually run out of space, we can't see adequately, we could have carried on and done an AP resection, but we're wanting to do a low anterior resection. So we convert and we decide that we'll go to laparoscopic. The view is worse. And then the view is worse, we think, well, we'll go to open, and it's even worse. So we say, well, we wish we hadn't even converted in the first place. And there's no doubt the best view, if you can't see it properly with the robot, you're not going to see it with any other way. This is where the arguments for TAR TME may come in, but those situations are quite rare with the robot where you can't actually get a vision to get down to the lower end. And with the more experience that one has with the robotics,
that must be due to your placement of retraction and retraction of the rectum out of the pelvis, because that's how you get space.
Well, the retraction out of the pelvis is there's another little thing that we do with the nylon tape, is that I put a nylon tape around the rectosigmoid. So we go through the fat, round the rectosigmoid, tight, and then we use a grasper on the rectosigmoid, which also means that you can get quite a lot of retraction, firm retraction out without tearing tissue out of the pelvis, and that helps a lot. And then you've got
where's your lowest nylon tape exactly?
The lowest nylon tape is the one that we put on just before dividing the rectum for the.
So it's really across the top of the anal canal.
Exactly.
Top of the anal canal. The lowest one goes right at the end of the TME, where you get to the muscle tube. That's where we put the lower tape. But at the beginning of the operation, we'll put one on at the site of the rectosigmoid, so that we've got that for retraction. Move it left, right, and pull it out of the pelvis.
I think one of the things that I've noticed with a lot of laparoscopic TME was the difficulty of, as Bill talked about, traction and counter-traction with laparoscopic. And it seems to me as if some of those difficulties have been partly tackled by the robotic.
Well, I think certainly from my perspective with the robotics, and having learnt that traction, counter traction, I'll use two instruments, and I tend to, rather than going right down the back as we used to do with the open, then coming round to the sides, I now go down the side on the right side as almost my starter. I find the TME plane at the beginning at the back, but then I'll come round count the sides, identify the nerves, and then come round the side, but all with two of the robotic instruments, one applying traction one way and one applying counter traction the other way, to open it up and coming up with the either the electronic scissors or the cautery, electronic cautery with scissors, or with a hook occasionally. I tend to prefer the scissors now because you've got more versatility.
That gives me a particular question, because you like the harmonic scalpel for a lot of your dissections, I think.
Not in the pelvis.
But not in the pelvis.
Not in the pelvis.
I found that seems to be universal now, virtually, that monopolar diathermy dissection, traction and counter-traction, like I used to teach in open, is actually the preferred technique for the bottom of the pelvis?
Laparoscopic or robotic, I prefer that. That's my preferred way of doing it, because I think you can get a precise way to find the plane.
Yeah.
I think it's very interesting, Mark. I haven't seen people use that upper tape, which makes a huge amount of sense. If you put a tape around the sigmoid colon.
Which bit of the sigmoid?
Well, just when it's coming to the top of the rectum.
Where you can have
rectosigmoid, yeah.
Where you right up against
if you're too high, if you're too high, it doesn't work, and obviously you don't want. If you go too low, you're going to get into the mesorectum. So you're staying clear of the mesorectum.
Because there's no doubt that trying to pull hard on a grasper on the bowel or the peritoneum, it won't work.
You can't do it. No.
So that's a really good trick, and I think this is where probably there are lots of educational aspects, tricks and tips that actually would help, and I think it's really important. And some of those robotically or laparoscopically.
That works robotically and laparoscopically, yeah.
The key thing in open surgery, and it can't be that different in any other, is the lifting forward of the vesicles and the bladder and the prostate in order to...
Yeah.
And I know one of the tricks that you can use in robotic is to rotate the camera at the bottom of the sacral curve, and you can dissect.
That's with a 30-degree scope, of course, which I tend to use a 0. I've never found that a 30-degree helps me. I don't tend to use a 30-degree
really,
because I find it, and I know some people will disagree, but I find the 0 does the job with the robotics.
You see, Amjad will put the 30-degree at the back and rotate it and come forward right up to the back of the puborectal sling.
And I think you can still do that with the 0, but providing you've got the retraction on it. There are situations where it would definitely help.
My question, how do you retract with the robot in the way that a strong registrar would retract with a St. Mark's retractor?
Yeah, well, you've got the various forceps, the blunt forceps, and if you just open the blade slightly, you can use that as a retractor, particularly in the area of the vesicles. That works very well. Lift that forward, and you can use the other arm to retract downwards. That'll open up the plane around Denonvilliers, and you can do a similar thing at the back with one of the robotics arms. You just lift things up, but you've got to be careful not to use something like a Maryland's, which might have a sharp point on it, because you don't want any sharp points going into the mesorectum. But you can get that pressure. If you're concerned about putting too much pressure on, then I'll put a swab with it on it, and that just dissipates the pressure a little bit as well.
You probably don't need as much retraction, though, Bill, if you have vision and articulated instruments, as we almost need more in open surgery. I'm convinced.
Well, we're linear, aren't we? Really?
As long as you can see, that's the key. And I don't think you do need the degree of retraction.
I don't think you do. You just need to see the tissue planes and have them under tension, which is what you always said. So I think there's no doubt that a lot of people get worried and get lost and maybe change the operation when they come to that decision where you've got the total mesorectal excision has been performed, and now you're left with a very low muscle tube, and the question is what to do about that. We've always felt, and you agree, that actually if you have a cancer in the lumen, that you should be washing out the lumen, occluding the lumen, washing it out, and then putting your eventual staple line across a washed muscle tube. And that is the difficulty, isn't it, in doing that. So people say, well, the evidence is very small for washing, but I think...
There's good evidence from Sweden, I think, from the Swedish registry, that where washing was left off, there was at least double the local recurrence rate.
And I think my view was, from watching it, evidence or no evidence, it made logical sense to do it. But the other aspect is it takes a few minutes. Well, what's a few minutes in terms of dealing with a local recurrence compared with dealing a local recurrence? And if you've saved 2 or 3 local recurrences in your whole career, well, you've done 2 or 3 people a great service, haven't you? So I don't see any disadvantage to do it, other than it probably taking you 2 or 3 more minutes to do it. It's not an issue.
I think it's not, but actually to get an occlusion across the muscle tube and then wash and then go below that has been the challenge, hasn't it, Mark?
It has been the challenge, but I say since the very beginning we've used this nylon tape, and used correctly. If you put the instrument onto the knot that made the knot, and then you pull it against the instrument, you can get a really tight seal. And it maintains it. And the added advantage, you can manipulate the rectum holding the tape without tearing any mesorectum, and in most cases you'll get a laparoscopic stapler across in one hit, even very low. It may take 2 in a proportion. Failing that, you can make the Phalanx steel a bit larger and use a conventional stapler down below it.
Because one of the things that Bill and I have always said is that the advantage of putting on an occlusive staple line is that if you need to do a bit more dissection as well, you can dissect below it a bit.
The upward traction on the first TA45 was the key weapon in triple stapling, the Moore and triple stapling technique that Brendan published.
If you remember, Bill, the original publication was, because we only had TA60s, is you put a staple line on and you left it, and then you made sure you got the next staple line below that staple line, but you don't have the traction to pull up on it.
Covidian, now Medtronic, they made the TA45 for us, and they still tell me that that's the biggest selling of those linear staplers.
But I think the evidence, Bill, is, as you say, is quite good. There is on the Swedish registry, in patients who had restorative anterior resection, there was a 5% reduction in local recurrence by washout. The only problem, of course, is the people who believe in washout believe in maybe they believe more in the whole concept. So it's not a randomized controlled trial. But what it makes the other thing is actually washing out. It reduces infectious complications, I think, because you're washing out the debris, so you're actually washing out that as well. So it's got to make sense. It's got to make sense. The question then is how you do it. So I think we all believe that, and I think a lot of surgeons believe there's no harm in the world in washing out, and potentially a lot of good. But I think people then skip that because it's not that easy to do, and probably finish up with the occasional local recurrence as a direct consequence. And I think the trick that you've described is very good, but I presume that in time we can probably get better technology as well, because you said that a laparoscopic or robotic stapler is now capable of it's a 60 centimeters stapler, isn't it? So
I think there might be a 45 as well. I'm not quite sure, but there are the robotic staplers now. So yes,
so that you may in time be able to get it, because Bill's concept of doing the ultimate anastomosis from below is another. Of course, we've always done that occasionally, Bill, haven't we? We've always done a transanal hand sutured.
We haven't been purse stringing from below routinely, but I like the Antonino's idea.
And of course, we've always, on occasions, for various reasons, sometimes because the lower staple line disrupts, we've had to do hand sewn coloanal, take out the bit in between and hand sew from the bottom.
Yeah, we've certainly done that.
And I think, in one sense, if you really are focusing on restorative low anterior section, you have to be able to do a hand sewn coloanal, because that will work. Isn't that right? But we always do that occasionally.
The advantage of doing the TT part of TTSS is that you do, I know there's the risk of contamination and implantation, but that if you pay enough attention to the dissection from below through the bowel wall, and doing it layer by layer and taking a lot of trouble, I think you can get over those objections. And I think you are optimizing, first of all, the clearance of the cancer, which is quite difficult to be that sure about in minimally invasive surgery from above. Very often, I think there are more bowel is taken away than needs to be, or perhaps going too close. But you're also optimizing what you leave behind, because we did have a Basingstoke publication which showed that a function for an anastomosis at 6 centimetres from the anal verge was much better than one at 3. So, you know, it's the idea of optimizing both,
yeah, absolutely,
is good, I think.
Yeah.
Now, can we just cover a bit, going back a bit, because I think it includes the discussion we're just having. The training, my impression is that we need to be really careful that we're not just training people on machines and robots. So we need to put all the fundamental TME as the background. So I have a concern, Mark, and this is where you and Tom need to focus on. People need to focus on, particularly for rectal cancer, all of the things we have learned over the past 40 years from Bill and you and us. We need to really say it's not just how the robot works. You need to focus on the whole operation.
Oh, absolutely, and I think that's what we do. And I think with the minimal access approach, either laparoscopically or robotically, one demonstrates it more clearly than we did with open surgery. And
there's a lot of teaching potential in those images coming out of your machines that we are not always using for the people who want to learn.
So,
I mean, I think almost every operation there should be a screen somewhere in a coffee room where people can just sit and watch.
And I think it's, you know, the technique. It's much more about teaching the technique for the operation itself rather than the technology. The technology, it's just a tool. It's a tool. It's a tool, yes, and the vital aspects of the various stages of the operation.
And I've always wondered, and I know we don't do it, whether we should have a plan. In other words, you know, that we work through a written plan, and the machine could easily tell us that, you know, splenic flexure mobilized, high ligation of the inferior mesenteric artery and vein, the things that we've put into the steps of TME, Bill, whether those all should be, there should be almost a sort of a
well, I think they are, and I think one of the things, if we take splenic flexure, I remember doing splenic flexures and never really being taught how to do splenic flexures, and one guddled one's way through it to bring it down. There was no specific technique. It was always a little bit of a fiddle, isn't it? It's up
I think
and we couldn't see what we're doing, but we actually, with the laparoscopic, we developed that medial to lateral approach. There is a step-by-step way, which is the same every time for dealing with the splenic flexure. So there's actual technique that we can actually teach, which we couldn't in open because we were so worried about damaging the spleen, which was probably damaged by traction rather than actually by any instruments. I'm sure it was the pulling down of the stuff that traction that caused the tear. And we don't
the
have
band of Gurevich was pulling on the splenic capsule.
And laparoscopically, we don't need to put that tension on it. So, and I can honestly say, in the whole of the time from starting laparoscopic right through robotics, I haven't had to take a single spleen out from doing that. But before, yes.
Brendan and I can't say that.
But not since starting the laparoscopic have we had to do that, because you're not putting that tension on it, and you can see very clearly where the tip of the spleen is and the bit that you need to dissect, even in a difficult one. So.
And I think that that's one of the benefits in the LabCo training, when you were a LabCo trainer, Mark, was that you designed these GAST forms, global assessment of surgical forms, so that actually all of these things should be documented, splenic flexure mobilized and how, and so on. But there is a concern, I have a concern that people will focus more on the robot than on the whole.
No, I disagree.
Well, I hope not. Well, that's your job to make sure that doesn't happen.
Yeah,
because
I think the principles of the operation remain the same and maintain their importance. The robot Laparoscopy is just a tool, like scissors, scalpels, and forceps.
But the great benefits of the robot is the ability, as Bill keeps saying, to collect a lot of information. And we talk about this artificial intelligence all the time now in every format. But actually, the information is tremendous that can be collected and analysed, can't it, Mark? And and to combine that with some of the planning that we could get from MRI scans. In other words, the depth of the pelvis, the size of the prostate, the angles of access and the position of the tumour, combining that information, which we don't use very much, I think it would be really useful. So I mean, Bill has mentioned this a few times, and I put it on my list as well as the whole aspect of artificial intelligence in robotics, because there's an overlap, isn't there?
I believe it's already there for hip replacement.
Really?
If not, I don't know that it hasn't. I don't think it's been used, but I think the technology is there to be able to do a hip replacement by pressing a button.
Really?
I understand, and I don't know any more than that.
The difficulty for TME with collecting the valuable information for AI is that it's the traction and counter traction precision. You are opening a plane all the time, and how you record exactly how you've done that with your robot. That's why I asked, how do you lift and you've answered it, but I'm not sure how easy it is to record exactly the equivalent of those forward, the opening of the plane all the time.
And we don't need to open it as much for laparoscopy or robotics as we do when we're doing it open, because we're working in a tight space and probably only need to move it a centimetre, and you've got the camera down there and the two instruments side by side.
You've got to put the point where you cut the areolar tissue on stretch, haven't you?
Yes.
Because you're using monopolar diathermy to stroke your way through areolar tissue. But in order to do that, it has to be on stretch.
And I think you're right, Bill. As I said, I think I said already that the robotic technology probably could do an easy case, but there is a fundamental difference, isn't it? Because the reason that robotic prostatectomy took off was we always know exactly where the prostate is. It's always in one place. Can't be anywhere else. And it's a
very variable size.
Variable size, but it's always, you know exactly where it is, and it's in the pelvis, and it doesn't move very much. Whereas and you don't have to move.
Moves more than you. I've got some pictures of it. It moves more than you think, actually.
But not as much as the muscle tube and the mesorectum.
And the rectum moves a huge amount.
Bill's point, but I think it'll come, won't it? And there'll be some mechanism for recognizing tissues and recognizing the right plane, Bill, because of the tissue structure. It'll come.
And this point I make, that I think it should be impossible for the thing we cut with to cut by mistake into the internal iliac vein.
Well, that would have to be an essential, wouldn't it?
It shouldn't be near the
it shouldn't really be near it.
But that's what I'm saying.
But it does get exposed on occasions, doesn't it?
I've got a beautiful picture of a very experienced laparoscopic surgeon making an electric hole in the left internal iliac vein.
It's a lively moment, isn't it?
Yeah.
Yes,
it's an exciting moment.
And I think also the ability to analyze the steps and the efficiency of progression of operation by robotic is quite exciting, isn't it, Mark?
And it's important, I think. And
the danger, it may become a bit of a speed game, though, mightn't it? There's a danger of people saying, well, I can do this operation in 14.5 minutes, and
if you watch the surgeons who really move quickly, they move through economy of movement quickly, and you watch the clock and it looks very quick, but the speed with which the instruments work is slow and methodical, isn't it? But you look at the clock and it's disappeared. And it's because each movement is making a step further in the other direction, and you can get another surgeon's moving very quickly, but nothing is really happening. So it's the economy of movement that's the key.
And where do you think the future of robotic technology is?
That's the $1 million question. I think it will develop and it will improve, and what we see now isn't what we'll be seeing in 10 years' time. You know, we look at the development of the Da Vinci system. It's changed hugely. Lots of things have been developed, and the CMR system is the same. You know, it's a fantastic company.
The CMR is Cambridge
Medical Robotics, and they've got a fantastic team. You feedback any issues, any concerns, somebody will take it on, an engineer will sort it out, and things will get changed. So as surgeons feed back to the companies, they're getting this information from all the technology that's recording all the information, but they're also getting the feedback constantly from surgeons of things that may be an issue, things that work well, and they adjust, and it will be altered to deal with that, and to get around the various hurdles that there are in some of these difficult operations.
Now, I travel a lot, and I have the feeling that I believed that patients did not want to have a bag on their tummy. And what I'm seeing is that lots of young registrars have been hyping LARS and making having a low anterior resection look or sound like a fate worse than death because of function. And people beginning to talk again about 30-40% of abdominoperineals. I actually believed we could get it down to 10%, and we should then look at the functional problems and perhaps introduce irrigation or something. What did you believe that people are doing too many APEs again?
Well, I think there is a variation, and it's difficult to get the exact figures of APRs, and it does vary from institution to institution and surgeon to surgeon. And I think it is possible to do these very low anterior resections, and well, Eric Roulier in Bordeaux is a fine example of how low you can actually go, but the people in that part of France do not want stomas, so he's had to adopt his surgery to avoid doing the surgery with very, very good results. I think our rate is probably slightly higher than that, but we do go very low. But I think LARS is a very real condition. There's no doubt about it. People do get low anterior resection syndrome, but the problem is if you go straight to an AP for the reason that, oh well, it's a low resection, you're going to get LARS. You haven't given them the opportunity to see what the symptoms are like. And certainly in my experience is doing these very low anterior resections, a proportion of those people will get low anterior resection syndrome. But when you say to them, well, would you like to go back to the stoma? Invariably, apart from a few exceptions, they will say, no, I'll stick with this. So, and then you've given the patient the choice. You've done a low anterior resection. If it doesn't work, you can go back and give them a stoma. But if you've done an abdominoperineal resection, it's a no-choice situation. And to be fair, it's a devastating thing to mention to somebody that they're going to have a stoma. They don't. We see them all the time. We take it for granted, but it's a pretty devastating thing to have to tell somebody if they've never had any experience of it.
I think
they may manage it very well, but they may not.
The only thing, Billy, because we did a lot of work on LARS, and I know, but what we found, and I personally believe it, and you've seen it all the time, is if you combine preoperative chemoradiotherapy and a coloanal anastomosis, a lot of those people have a lot of trouble, and therefore you need to be really careful when you're using preoperative chemoradiotherapy, and you need to think it through. And you know, I have to say that if I have a patient who's had preoperative chemotherapy, they often come to me. I say technically I can do this, but the risks then become much higher. But I agree. I think if you can operate on a person who has a low rectal cancer, and you can do an anastomosis which doesn't leak, then I think the vast majority of those patients get good function. Not as good perhaps as it was before, but most of them are very, very happy. And I've inherited some of your patients still come to see me, Bill, and they have excellent function. And we have some people who are gone past 100 who have had a restorative procedure. But I think the problem is when you add in preoperative radiotherapy and you add in the possibility, you know, a very low with maybe a leak, then I think the risks are bad. But I agree. I think we spend and then we get back to what we were talking about last week with Gina. is if you expand the use of chemoradiotherapy, then you will probably make function a lot worse. I think that's it.
Well, then we can get into the argument of we're probably giving far too much radiotherapy around the country, aren't we? And yes, you've got the argument for saying, well, we can give radiotherapy and you may get a complete response, but probably it's only, certainly from our data, it's only about 13% get a complete response. So most of the people you're giving radiotherapy for are not going to get a complete response, and you're going to compromise your operation and the functional results afterwards. So you can significantly, I think, safely reduce the radiotherapy rates from what are being given at the moment without an increase in your local recurrence rates.
Whereas the NICE guidelines, or at least the national guidelines for this, are now suggesting that all anything bigger than a T2 should have radiotherapy, which is totally against all the teaching that Gina has been generating for the last 20 years.
And effectively,
and I think across Europe, they give almost everybody gets radiotherapy first.
You're treating inadequate surgery by giving radiotherapy, probably. Well, you could argue.
You could argue.
And I think the other aspect of radiotherapy, which people continue to disagree with, is there's no question preoperative radiotherapy, short course or long course, it affects anastomotic healing.
Yes, it does.
So actually, if you add in the radiotherapy and the anastomotic risks increased. And I think that's where, Bill, that's where my coming at low anterior section syndrome is. If you have a person who has a very low rectal cancer and they've had chemoradiotherapy and they haven't had a complete response, then you can still do a coloanal anastomosis, but I would warn those patients the risks are much higher. But I would agree we shouldn't be frightened off doing a low anterior resection based on the fact that they may have bad function. Because interestingly, I asked Soren about that. I said, Soren, do you ever see low anterior resection syndrome after a right hemicolectomy? And you do. So the symptoms after any bowel resection, you can get this urgency, frequency, feeling of incomplete evacuation, which is what. So I think occasionally people with right hemicolectomy get a lot of symptoms, but it doesn't stop us doing right hemicolectomies or giving them ileostomies.
No.
I think our approach for the radiotherapy, well, I know our approach for radiotherapy was for the ones where we're planning an anterior resection was only to give it if the margin, the mesorectal margin was threatened by the primary tumour. Lymph nodes we ignored completely. Primary tumour had to affect it. N2 we didn't give radiotherapy to, but if it was a T3 tumour getting close to the margin, they'd get radiotherapy. For a patient that we decided needed an abdominoperineal resection, we'd give radiotherapy for, because you get a proportion of complete responses and then they don't have to have any operation, but they're going to have an AP anyway, so you aren't affecting your anastomosis. But with that approach, it was only about 8% of the anterior resections ever had radiotherapy preoperatively. So, and
8%. That's about the same as Amjad.
8% with local recurrence rates of about 2.7%. So you don't need it if you're doing the TME.
Our results are similar. In fact, we're looking at the St. Mark's. We've got a combined paper with St. Mark's that Gina has Amy Lord working on, and it's exactly that, to it, 2-3% local recurrence. I think we've probably covered. We could stay here forever. So Mark, it's been a pleasure.
Thank you.
Thank you very much.
We'll learn to all from this, good man.
Thank you.
Thank you, Nick.
Thank you.
You can find a whole series of videos and links to our series of discussions around rectal cancer at this address. And if you have any suggestions what we might cover, please let us know. Thank you very much for joining us.